Hey guys, welcome to another episode of Civilian Medical Podcast. This is episode 66. Man, we're getting up there. Like I've been recording, listening and recording back to our old episodes, and like we're like 50 now, going back on YouTube channel. Like, oh my gosh, this was like during COVID, like pre-COVID. So 66. So pretty excited about this one. Not because Prep Medic's here. He did at least get dressed and like looks halfway decent for this one, but we have Lindsey here, and like she definitely is smarter than us and works out harder than us, and she's gonna beat us on Instagram very quickly. Lindsey, introduce yourself.
Hey guys, I'm glad to be here. Yeah, most people know me on Instagram as the Prehospitalist. That's my kind of outlet for pouring out education to whoever wants to listen. But so I currently work as a flight medic, but I'm a baby flight medic. This month is my 2 years with critical care flight services. So had a lot of fun doing that, have learned a ton. And then of course, leading up to my flight career, I have like 15 years on the ground, both volunteer and career, which is where a lot of my inspiration for my educational topics come from.
And we tried to talk you into a YouTube channel too, didn't we? We never could get off the ground.
No, she got one. She got one. She has one.
Okay. First of all, my YouTube channel is trash. Prep Medic tried to help me. He was like, let me help you be better. And I was like, no, I'm just going to use a whiteboard on my couch in the living room. So I have like 4 videos that are basically by request when people have topics. But yeah, don't subscribe. It's not good.
You should definitely start a YouTube channel.
Oh, yeah. It's there. It's there. It's just not good.
I will help you pass Prep Medic. Like whatever I can do to help you get past him. I can push from behind now. I can't lead anymore. I can push from behind. And I do have my co-host here, Prep Medic. So thanks, Sam, for coming on.
Yeah, you're quite welcome. You don't sound quite sold on that one though.
I'm just gonna like knock you out, and it's just me, Lindsey, and I talking for a little bit. So
yeah, it's probably better.
So this episode is going to be sponsored by Primary Arms. We appreciate them sponsoring our podcast. They just released some AR-15 uppers that look really cool. I'm pretty excited to take a look at them. I'd like to shoot one of them. Hint, Primary Arms, if you'd like to send one, don't send any of those other guys. Just send them to me. They have a 16-inch. I was looking at 11.5-inch, 10-inch. They're all American-made uppers, which is something that a lot of people, I think, really want, is an American-made product. So I'm excited to see where this goes, and I'd like to shoot one.
Watch, they're going to send one to Lindsey and not either of us.
Oh, my husband would love it. Please do.
That would be
on the page.
Yeah, dadgummit.
So what are we talking about today?
Oh, so I thought we should talk about Narcan because we all agreed we'd love to get people fired up and lose some followers over this. So, where I worked on the ground before I started my flight job, this was super common. And I know that's overdoses, that is, narcotic overdoses. And I know that's really relatable for a lot of people. Some people in other parts of the world don't see this very often, but most, especially urban agencies, but even a lot of suburban agencies here in the States, I mean, this is it's a daily occurrence, if not multiple times a day. And as an EMS educator, one of the biggest things that I always hear people talking about is this idea of, you're going to wake someone up with Narcan and they're automatically going to be combative, right? And that just really irks me so bad because while it is possible, and yes, we're taking away their high and they're not going to be happy, I wholeheartedly believe that the majority of the time when that happens, it's a provider problem. It's not a Narcan problem. And so I think this is relevant for the entirety of your audience, those who are medical providers, but also those who aren't, because Narcan is super accessible to everyone nowadays, right? Like places give it out for free. Law enforcement has it. Families have it. They give it out with prescriptions at the pharmacy. So it's really relevant. And I think we should talk about some ways that we can make this process of waking up from an overdose a little bit happier for everybody.
Yeah, we've got a lot of preppers that watch this show and then watch both of our individual YouTube channels. And, a lot of people that like to be medically prepared. And I think a question that's come up on every single everyday carry video I've ever done is, what about Narcan? Why don't you have Narcan in your ankle rig or whatever it is? And then, of course, we've got, all the police departments sharing all their Narcan stuff and fentanyl scares. So, yeah, I agree. I think it's totally relevant. Just to recap really quick, Narcan is basically the reversal agent for an opiate overdose. So if somebody took heroin or fentanyl or morphine, something they overdosed on it, they've stopped breathing, Narcan's kind of the med that's going to help them the most in that, just for anybody that might not be familiar.
Yeah, I think that's important to talk about because you said it only works for certain medications. Like this isn't like a cure-all. Like, oh, they're just because they're unconscious, not everybody should get Narcan. And I think that's something we've seen in the past where bystanders, family members just start shooting Narcan. And although we don't really know of any major side effects, it's still not like there's other issues. So Narcan is not a fix-all drug.
Yeah, and it's important to understand like what kills these people, right? So, someone has a family member or comes across a bystander that used heroin and maybe they didn't realize it was laced with fentanyl, and they become lethargic and eventually go unresponsive. The problem with narcotics is that it decreases respiratory drive or, in some cases takes it away completely. And so these patients become hypoxic, their oxygen levels drop lower and lower, and eventually that leads to a cardiac arrest. So they stop breathing for so long, it's so inadequate that their heart stops. And, we can probably circle back to this at some point, but all Narcan does in a patient who is still alive is allows them to start breathing again, right? It reverses that respiratory depression, knocks the opioids off the receptors, blocks their actions for a time being, and allows them to start breathing. But if the patient is already dead, Narcan's not going to do anything, right? They need CPR, oxygenation, and ventilation. Narcan is not going to save their life once it's gone too far.
And I think that's something that can't be emphasized enough, is that we see professional providers even walking into a room and they have somebody suspected opiate overdose and they push Narcan and they don't do anything else. Like we think like, oh, it's not the same kind of respiratory issue because it's not actually respiratory arrest, it's a narcotic overdose. When they should be, yes, getting Narcan out, but maybe in the meantime putting in an NPA. Maybe bringing out your bag valve mask, doing rescue breaths for the patient, providing supplementary O2, like doing all of these standard things that if it was little old lady down on the ground not breathing, we would do. But for some reason, I feel like narcotic overdoses short circuit a provider's brain to think like, oh, it's okay, Narcan will fix everything.
Yeah, I completely agree. And it also goes down this direction with narcotic overdoses that I feel like they tend to bring out some of the worst in EMS providers. And there's this just like feeling of ego that comes out sometimes. And I understand that providers are frustrated, right? They're tired. They've probably Narcan the same person this week, if not also today. It's frustrating. But that's not an excuse for us to be lackadaisical in our care for these patients. Like what is hurting them right now is their hypoxia and their hypercapnia. And there is absolutely no excuse to not be ventilating those patients with oxygen while we wait for Narcan to work, because either someone is taking the time to start an IV, which is going to take a minute or two, or they're giving it IN, which is probably the most common, or IM, which a lot of law enforcement agencies are carrying both of those, and those can take up to like 5 to 7 minutes to work. So what, you're just going to be lazy and let your patient lay there blue as a blueberry while you hope that the Narcan maybe is going to work? In my book, there's no excuse for that.
Yeah, but we see it a lot. Like we
all
see
the time.
Cops do it. All the time. We see cops do it. Firefighters do it. Like to pick on those, because we're the black sheep always as paramedics. So to pick on them a little bit, that I've seen cops spray 4, 5, 6 milligrams, 8 milligrams of Narcan in this guy's nose and just still sitting there with their hands in their pocket. I'm like, well, that's great. Just sitting as not a sinus cavity. That's great. Or the fire department who gives 4 milligrams nasal and then it's like, all right, EMS will be here shortly. So,
and I can't blame law enforcement too much for that, because
we can absolutely.
I don't get my panties too much in a bunch about that, because law enforcement, they're not medical providers, right? Like they're already, in my book, going above and beyond to help these people. I don't expect
oh my gosh.
Like our providers can't even use a BVM. Like people who are trained on a BVM can't even use a BVM correctly. So we're going to expect, cops to learn how to do that. And it's like, so if they want to stand there with their hands in their pockets, I don't really care. But the fire department no excuse. The ambulance, no excuse. Anyone with formal training in airway management, there's no excuse for that.
Interesting. I was going to take that the other way and say, like, we need to just train up get rid of law enforcement's Narcan, retrain them in rescue breaths, and then go from there. That would be my take. But, I get it. And that makes a lot of sense, is that we don't do a good job of doing bag valve mask respirations all the way at the top of flight medicine. We don't do a good job. So I get that.
Yeah. Because then
Did you
you're
guys
just
see
going to
the
have
video
an
from My Medic? Sorry.
No, go ahead.
Did you guys see the video on My Medic where they were talking about how we over ventilate our patients with more tidal volume because they were like squeezing the bag and they were measuring how much we were actually giving? And really, like an adult BVM, like they were just barely pinching the BVM to get, like, I forget what they calculate, but basically the 5'10", 200-pound patient needed like 400 or 500 mLs, and like you could barely squeeze it and you're getting enough there. And I was like, man. So yeah, we do it. I showed it to all my EMT students. I was like, hey, stop squeezing the BVM. Like, don't squeeze with 2 hands. Just squeeze just enough to get chest rise. Like, really started walking through that because we do a terrible job. Like, we generally probably put the newest EMT, the newest paramedic at the head and go, all right, I got to go do some cool paramedic stuff. I need you to bag this guy. And they're bagging 3 times a minute, or they forget to bag the guy at all, or whatever. And I think this is a skill that we've lost.
You're going to get me on like a totally different soapbox than what we even came here to talk about. But man, this gets me so fired up because, like, if you look at the adult BVM, the tidal volume that an adult BVM is capable of delivering is like 3 times what you need for an adult. And so just like you said, we end up, on a code or a critical patient, putting the newest person at the head doing what is oftentimes the absolute most important job. And they're not using good technique, and they don't have a good seal, and they're not getting good chest rise and fall. And it's so important. But I know for us, like at work, in our bag that goes in with us everywhere, we just carry a PD BVM because a pediatric BVM can be used for everybody, even an adult.
Yeah. And then when you start, like, you don't realize how much you bag people, because I think the adult BVMs are between 1,000 and 1,500 milliliters, which, I mean, the tallest man in the world wouldn't take 1,500 milliliters. And you start looking, when you start doing vent titrations and you start calculating ideal body weights and you start calculating in there, you realize that, like, I very rarely set a ventilator for over 500 mLs of air. Right. Very, very rarely. I feel like everybody is in that, 425, 450 range. So the fact that we're giving somebody a 1,500 BVM is absolutely insane.
Agreed.
So what is the controversy with Narcan? So we kind of covered what it is, but like we're here to talk about like some Narcan management. What's the problem that you see with this medication?
Oh, there's so many. Like, there's so many problems that we could talk about. What I don't necessarily want to get into, I think, is dosing, because that's really dictated by your protocol. What I didn't know until recently is that some places, especially overseas, not in the States, but there's places here that do it as well, that they give doses of 0.04 milligrams, titrated super tiny doses to respiratory drive. And I thought the first time I read that, I thought it was a typo. I thought they meant 0.4 milligrams, and they didn't. And I heard it on another podcast recently too, which is insane because based on the concentrations we get, we have to be diluting it. And, so there's dosing from those tiny amounts all the way up to people getting preloaded syringes with 4 milligrams, 8 milligrams in them, right? So we could argue about dosing and the best route and the best way to do this. But at the end of the day, it is a fact that EMS providers and bystanders are going to find themselves in a room with a waking overdose patient because everybody has Narcan. And so no matter how we may have liked to give the Narcan, if a call goes out and it was dispatched as an unconscious or a cardiac arrest and law enforcement gets there first, or family has Narcan available, they've already given 2 milligrams, 4 milligrams, 6 milligrams, maybe 8 milligrams. And when EMS providers get there, that patient is often already starting to wake up or is going to be waking up in the near future. And the biggest kind of controversy I think that exists is this idea that Narcan makes people angry and combative and hostile when they wake up. And there is, of course, some truth to that, right? It is reversing their high. It's putting them into an immediate withdrawal that does not feel good. But anecdotally, as someone who has given a ton of Narcan over the years, I think there are some steps that we can take, things that I've seen providers do egregiously wrong that elicits that response from these patients, right? So providers
don't call
go
him a
in,
moron.
huh?
Don't call him a moron.
No. I think there is some tendencies, and it, comes from burnout and frustration and ways that providers end up managing or not managing a scene that causes a patient to be hostile when they wake up. And I think there's a lot of ways that we can mitigate that and make the situation easier for everybody.
Yeah, and I've seen the same thing. I've never had a patient wake up swinging at me. I've had a patient wake up and be a dick.
Yeah.
But not anybody that's actually caused me or threatened to cause me physical harm.
Right.
I've personally never seen it in 10 years of EMS, and that doesn't mean it's never happened to anybody, but I was always taught the same thing of like, oh, be careful, they'll wake up swinging at you, and I agree. I don't think that's that as common as we make it seem like it is.
Yeah, exactly. And so, like, the first thing on my list of mess ups here is that, we already kind of talked about that these calls tend to go out as overdose, unconscious, cardiac arrest. Everybody and their brother shows up to the scene. And because that patient may be unconscious when we get there, people just start swarming them, right? There's firefighters around them. There's the EMS crew around them. There's cops around them. Maybe family or friends are frantic around. And so if they've already been given a high amount of Narcan before we get there, or even if we give the 2 milligrams or whatever, and they start to wake up, they wake up with all these people around them in uniforms with radios chirping and blaring. And it's going to set you up for failure, right? They're going to be, these patients are always disoriented when they wake up. And so for them to wake up disoriented and feeling like shit, surrounded by strangers in uniforms, maybe cops, which is probably not what someone wants to see, that knows that they just use drugs, that's going to elicit a bit of a panic response. And when people get scared, they get violent. So one of the first things I do in that situation, if I know someone's going to be waking up soon, they're starting to rouse, is I clear the room out. Like, I just get rid of people. And so once they sit up, I back up, I give them plenty of space. I give them a moment of quiet so they can orient themselves before I even start talking to them. And I think that starts things off on the right foot.
Yeah, absolutely. Do you do anything, or have you found, like, just looking out for your own safety, trying to do like an assessment on them before you actually get that Narcan on board, before it starts working, just to make sure they're not going to pull something on you?
Yeah, I mean, it's always good practice to do a full assessment before, if you can, right? And so, that's kind of a different situation. We walk in, we haven't given the Narcan yet. For me, that's a different boat, because if they are totally out, first, I'm going to make sure this is actually a narcotic overdose, or at least that's my best differential. Do they have the pinpoint pupils, the decreased inadequate respirations? We're going to check a glucose. We're going to do, maybe some quick vitals, or at least get a sense of their hemodynamic picture, right, before moving on. Is there any trauma, things like that? But probably the biggest thing I'm going to focus on, if I'm the one giving the Narcan, is oxygenating and ventilating beforehand, right? So yes, withdrawal makes people cranky, but so does hypoxia and hypercapnia. So if I can give someone a couple minutes of oxygenation, good ventilation, while we're getting that Narcan prepared, while we're getting it to work, then that also guarantees a happier wake up.
Absolutely. So don't crowd them. Get people out of the room. There's no reason to have 2 engine companies standing in there. They'll help you lift if you need to, but hopefully they're going to walk out, right? So
yeah.
I like that. What's the
Um,
next step you are looking at?
Yeah. And, you know, by the way, let me just add that there's no hate on law enforcement here. Like, I'm married to law enforcement, like full support, but like patients hate you, you know, and it's like, sorry, I don't hate you as a law enforcement officer, but like, if they can understand that sometimes just taking themselves back out of that situation, that can make things a little bit easier for everybody.
Or
I
just
think
out of
it's where
view,
the
like,
uniforms getting mixed up
Right.
of like
Exactly.
because we may have a badge on looks that says oh paramedic here, but at the same time, like that is
Yeah. They
yeah.
don't know the difference.
Yeah, they don't know the difference. So kind of like you, I like that idea, clearing out the room and kind of going have maybe just one or two providers in there and kind of clearing everybody
Yeah.
out because it kind of goes along with your next thing you're gonna talk about, you know, and I think cops definitely want to know that. Like so they're gonna
Yeah.
immediately jump on them. So go ahead with that.
All right, number 2. This drives me absolutely insane when patients wake up, you know, they sit up, they're disoriented, and some firefighter with their like handlebar mustache in the room is like, "What did you take? What did you take?" I'm like, dude, like he had pinpoint pupils. He wasn't breathing. We gave Narcan. He's awake. What the F do you think he took? Like, what do you think he took? Because a hint is that it's a narcotic because he presented like a narcotic and the antidote to the narcotic works. So do we really even need to be having this conversation right now?
So we can't crack on cops, but you can crack on the volunteer firefighter.
Yes.
Gotcha. Okay. All right. Now we got our ground rules set. We're good. So
Yeah, you know, just different playing grounds there. So yeah, it drives me insane. And I don't think it's inappropriate to ask it at some point. I mean, that is part of our assessment, right? But right when someone's waking up in this mess, you know, again, surrounded by radios, uniforms, they feel like crap, they're disoriented. That is a very offensive thing to be asking somebody. And it's accusatory. And just who cares? Like in that
exactly.
moment, it does not matter. So my personal preference is to get the call going and figure out which direction are we going to get a refusal? Are they going to come with us? You know, whatever. And once things are a little bit calm, be like, hey man, you know, your buddies found you unconscious, like you were barely breathing at all. Did you take any drugs today? Use any alcohol? You know, start it lightly. You know, you can always say, depending on the patient's demeanor, hey, we gave you the antidote to, you know, something like heroin and it woke you up. Did you happen to use anything? But this is where reading patients and reading body language comes into play. Because if you sense any hostility or defensiveness building with those questions, then stop asking them because it literally does not matter. Because all you have to do is document how you found the patient. Okay, that's your evidence of your narcotic overdose. If you saw any paraphernalia, that the Narcan worked, and that's it. Like nothing else matters about that situation. So why risk pissing off the patient by prying when you don't have to?
Yeah,
But
and
you
it's
could give them ketamine afterwards, right? You could give them ketamine. You could just say,
Ketamine
"Oh,
for everyone. Ketamine
yeah,
for everyone. All the
Sam
time.
can't do that, but
not in Colorado.
we could do it, Lindsay. Like you and I could do it, but yeah." So you're like, "Oh,
Sorry.
here's you're back awake now. Well, let's knock you back out because I'm too old to fight. So go back to sleep."
Yeah, asking as part of like a legitimate assessment is different
Yeah.
than an accusing statement because like
Yes.
I mean yeah they took an opiate but you know maybe it was a speedball, maybe they got meth in their system, we need to be
Yes.
looking out for you know potential cardiac arrhythmias or you know other issues associated with it. So I'm with you. I like asking a little bit later in the assessment, but like you said it doesn't freaking matter, and not asking it in a mean way. I think it's worth talking about as well with that is if you interview a patient and they admit to something to you, you can't go share that with law enforcement unless they were there with you. I think a lot of people forget that that's still a HIPAA protected conversation. And unless it's an immediate risk to somebody, you can't just go and talk to the cops about it right after it and be like, yeah, he said he took heroin. He said there's a gram of it under the bed. Like that's, if the cop wants to be behind the patient and listening quietly, that's one thing, but you know that's not something we can share. And I think that's sometimes worth reminding patients that their conversation with you is a protected conversation when it comes to healthcare.
Yeah, and that's where documentation is so important, you know, because Whatever happens after the fact legally, they will subpoena your report, right? So we just need to be really thorough and objective in our documentation. Remember to we don't put our thoughts and our feelings, right? Or what we suspect happened. It's only what we actually saw, using quotations around things that were actually said. I've been to court for these cases. I have been on the stand being hounded by defense attorneys about, a patient that says they didn't do heroin when I was the one that treated them. And it makes your job a whole heck of a lot easier if you can just refer to a thorough narrative and report that paints the picture perfectly.
Absolutely.
Yeah. So that kind of takes us on to number 3, which is, someone asks them what they took and they say, well, I didn't take anything. And this is where providers also, I've seen them and law enforcement, hound these patients. Well, yes, you did take something. And it becomes this battle. And to me, it's like watching kindergartners fight. Like, I'm like, what is going on here? Why are you fighting with this patient? Who cares? So, sure, you can give it a round of, hey, I know sometimes this is hard to talk about, but we did give you an antidote to narcotics and it worked. Are you sure you didn't take anything? And if they say no, then who cares, right? Leave it there. There's no reason to get offensive with these patients and get into like a pissing match about whether or not they said something. Patients lie. Patients who use drugs lie. It is what it is. It doesn't affect our job at all.
And it doesn't change your patient care, my patient care from 5 minutes from now, from 10 to an hour, really from now. I don't really care like what it is. Like, and I will talk to a patient just like, because maybe the patient thought they were buying a certain kind of drug and maybe they ended up with another kind of drug. I'm like, hey, you might want to watch your drug dealer. He kind of messed with you a little bit.
West Point cadets in Florida.
I'm like, oopsie. But yeah, so just, it doesn't affect my patient care one way or another, what you took or what you didn't take. So I'm here to make sure you have a good O2 saturation right now, and we're going to go to the hospital, or you're going to sign here. I'm out of here.
Yeah. I mean, like Sam said earlier, it is part of a thorough assessment if they're willing to talk about it. I know my area went through a few years where speedballs were a huge thing, right? So these patients have these wonky presentations of like kind of a downer and kind of an upper, and how they presented just depended on whatever their ratio happened to be that day. So if you can get that information, it's definitely interesting and can help inform your assessment and why your patient looks the way they do. But if they're fighting you in that response, there's no reason for it. The other thing that I've seen, I put this as number 4, and I hope that maybe this is like a limited experience to me, that I've happened to see this a fair amount of times. It just kind of blows my mind where people will load these patients onto the stretcher, right? They're getting ready to go. The patient hasn't woken up yet. Maybe for whatever reason, they've decided we're going to transport. The Narcan's on board, put them on the stretcher, and they start cinching down their arms in the straps, okay? And with the purpose of, well, when they wake up, we don't want them to be like swinging and combative. Okay, I don't know about you guys, but if I woke up amongst strangers, disoriented, going through withdrawal, strapped down, that would single-handedly make me try to beat the ass of everybody around me. Like, I would be like, who is kidnapping me right now? Why am I tied down on a stretcher, bumping down a driveway? I don't know where I am. I don't know who you are. I can't move. I'm terrified. Like, that is asking for someone to become combative.
That sounds like skinny medics, like normal Friday night.
More like prom night, but that's okay.
Oh God, I have questions. We had this patient that had a premise alert on his property, right? Because when some other crews would go there, he would get super combative with them and would be dangerous and whatever. And I remember walking into that house one day and the crew had him, strapped down. And I was like, well, no wonder this guy tries to beat you up when he wakes up. So I undid the straps, got people out of the room, did all the things we've talked about thus far. And when he woke up, he was a perfectly pleasant man. It's just, I think that is asking for hostility when you're inducing fear in someone that's already going to be confused when they're waking up.
Yeah, absolutely. I don't think there's really any precedent for putting like restraints on a patient beforehand. Like for us, we're not going to do it unless they clearly demonstrate that they're a threat to us at any point. And I mean, I guess air transport's a little bit different. Like we're a little bit more cautious, and I'm sure you guys are too, of who we load into the helicopter. But like, if you're just chilling for a second, waiting for that Narcan to take effect, there's no reason to just do a load and go on them at that point.
Yeah, exactly.
Yeah, I don't think I would never advocate for that. Like, I've never seen a crew do that. Like, I've always like, oh, now he's combative for whatever reason. Maybe he's doing some other kind of drug and he wants to beat our tails. And I'm like, all right, cool, let's tie him down. Like, let's do this. But the preempt, like, yeah, same thing. Like, if I woke up from, like, we've all had like that really good nap where you wake up and you think it's like some weird time. You're like, oh gosh, like that's kind of the same thing. I feel like you're gonna wake up to this as like, oh gosh, what day of the week is it? Like, what time is it? And you're tied down. Yeah, I'm gonna beat someone's tail. So.
Yeah, and I mean, I think it's even being mindful. It may not even be as aggressive as like physically intending to restrain someone, but if you lay someone on the stretcher who's unconscious and maybe you tie their arms in, right, with the seat belts, maybe it wasn't even intentional, but kind of thinking about what that's going to feel like to someone when they do wake up, like what you described. Maybe just keeping their arms out gives them a little bit more sense of control and freedom that can ease that transition a little bit.
Yeah, absolutely.
Yeah.
Nice.
All right, number 5. This one's pretty basic, but it just comes to not being a judgmental asshole. This is something that is kind of a pet peeve of mine across the board on all calls, not just narcotic overdoses, but when providers feel entitled to have opinions and to let those opinions influence their care and how they talk to patients. So don't get me wrong, we are all humans. We all have emotions, right? We all have our own beliefs. We feel certain ways about certain situations, but it is literally our job to treat every patient with dignity and respect to the best of our ability, right? And
this does not happen though.
No,
it does not happen. Like,
it doesn't happen.
There's plenty of research and data to show that we do not do this.
I 1,000% agree with you. And I think it rears its ugly head at the worst sometimes in these narcotic overdoses. And people just get so judgy, and it comes across in body language, in tone, in the words that we use. And what I try to tell all of my paramedic students is that there is absolutely no way that we can understand what that patient has been through that led them to that situation in our brief time with them. I understand that a lot of people think that it's a choice to be an addict, right? At some point, they said yes to that drug, and maybe you or I didn't. But we have no idea what trauma they've been through their life. Were they sexually abused? Did they go through some major tragedy, some serious family trauma? Like we don't know. So who are we to judge them for being in that position? Nobody wants to be an addict. Yes, they are. I guess you could argue they're making that choice to use, but it's not as simple as that, right? No. It's an addiction. So the least we can do for these people is be kind. There's just simply no reason. There's no reason not to. And I think when patients in any situation, but especially here in narcotic overdoses, when they pick up on that from us, whether it's nonverbal, it's just in our body language, our tone, that makes them more likely to be hostile towards us. And I have seen scenes escalate from situations like this, or even psychiatric emergencies or other kind of emotionally fragile situations, when the patient picks up from the provider that they are not empathetic with them and that they're judging them, that escalates the patient's demeanor. And that's asking for a combative situation that didn't need to happen.
Yeah, absolutely. I've seen a trend in some of our newer paramedics. It's almost like it's cool to be salty. And
Yes.
To be salty, you have to be a dick about it. I think you had a post about this actually a while back that we talked about a bit. But, you have the new provider that comes in, they're like 1 year of experience going on 30. And they think it's cool to be an asshole to patients. They think it's cool to, say something really stinging to these patients in particular. It's so inappropriate. And I agree. It escalates the entire scene. I think if you want to come at it from a point of compassion of like, hey, your mom found you. She's really worried about you. You know, you came really close to
Yes.
dying this time. Like, can I get you some help? Like, is there something I can do for you? Like, coming at it from a point of compassion to try to lead to change. Nobody's going to change because you call them, you know, a lazy ass addict that's choosing to do it. And our goal should be to help this not happen again. And we're not going to fix that most likely 9 times out of 9. But, you know, there's always the chance that something you said will spur them to go get some help, or like, oh man, because they don't see their parents getting worried. They don't see their friend trying to wake them up or put them in a cold shower or something like that. So like, I find sometimes just having that chat of like what that was like can spur somebody to go and get more help. And there's good data to suggest that addicts inevitably get help.
Yeah.
Not that they always clean up, but that they will pursue help at some point.
Yeah, I totally agree. Kind of using compassion and empathy and showing them that you care about how their family feels about them, how their friends feel about them. And you know, there's a lot of providers who go well above and beyond for these patients, right? Who will continue to support them, make sure they have the resources they need, you know, leave them with Narcan if that's something that the agency supports. And I'm not saying that everyone has to be at quite that level all the time, but there's no reason to be the opposite of that and be negative to these patients. And I agree. I think that this culture, it's almost like it's cool. And the argument that I hear from a lot of providers is that these providers are so frustrated at the abuse of the system. And I empathize with that. I get it. Like if you are on an overdose for the 3rd time today and a pediatric cardiac arrest goes out up the street and you're not available because you're here with this addict giving Narcan again, I understand that that's frustrating, but no one will ever convince me that that's an excuse to treat that patient like shit. It is simply not an excuse. And I hear too many providers using it as one. I'm not saying it needs to be rainbows and butterflies and we need to sit there and have small talk and talk about their life, but you do need to be respectful. Like, bottom line, we are paid to do a job. Someone on social media was talking about how like 911 EMS is far more people skills than it is medicine.
Absolutely.
Right? And I totally agree with that. So we are paid to be people, right? We are paid to have these interpersonal relations and manage scenes and get patients where they need to go. And nowhere in there in our job description is being a dick because we feel like we're better than these patients.
We're providing a service. I'm like, we're in the service industry. We are providing a service. Yeah. And you guys as flight crews, at least the ones around here, see that more than what the ground crews do. Because to me, like, I always feel like the flight medics are, we've called you guys. So we're providing a service for us. So you guys are always super nice to us, the ground crews. You're like, oh, thanks for calling, being super nice. But we forget that we're in the service industry. And I think it's because we have lost the middle age of providers. We have those providers who've been a provider 1, 2, 3, maybe 5 years. And then people who've been providers for 18, 20 years. Those providers that have been a paramedic for 10 years are gone. They've moved on. They've done other things. They went into nursing. They went into work at Lowe's, wherever else they wanted to do, but they got completely out of the service. And so there's no one to guide these young providers in the right direction.
Yeah, I agree. I mean, it's not really a good career option here in the US, unfortunately. You know, we've had some discussions online about this and about what should education standards be. But I mean, with the pay and kind of the culture of EMS in the US, it's just not something that's feasible for most patients or most people to make a career of long term. And I think that contributes to the issues you're talking about, where you do lose a lot of those really senior tenured providers who maybe have a little bit more level head, a little bit broader perspective on what's actually going on.
Some life experience, you know.
Yeah.
Me, like, that's what I see a lot of the new providers. I'm like, these are kids. And like, I was there too. Like, I was a 21-year-old. I'm like, oh my gosh, I had no life experience. So not having any life experience, I can't relate to that drug addict. I have a hard time talking to them. I can't be nice to them. So I'm just a salty 21-year-old. But yeah, I think that's the problem is we have so many new providers that we have new providers who are training new providers too. Like we have, men and women who've been a paramedic for 3 or 4 years who are now training brand new paramedics who've been a paramedic for 2 weeks, and no one really has the experience to kind of step back and say, hey, this is what we're supposed to be doing. We're providing a service.
21 years old. I got in an ambulance with an 18-and-a-half-year-old, and she made sure to tell me the half part about it.
Yeah, I'm teaching EMT class right now to high school kids. So these kids will graduate 18 years old with firefighter 1 and EMT certification. And I will probably be on the hiring committee that hires them to my EMS service as 18 years old kids. I'm like, oh my gosh, like, let's just get in the ambulance and go for a ride.
I still think about, I don't even know how it's allowed. And I don't know if this is just a my state thing. Like, how old do you have to be to get an EMT class where you guys are?
Finish, you have to be 18 in my state.
Yep.
So I got my EMT at 16, which is mortifying. I mean, I was literally a baby. I think about the first like horrible traumatic call I ever ran. It was like this single vehicle, fully involved. The guy was impaled with a fence post. He was incinerated. It was awful. I stood in the middle of the road and I started sobbing, like literally just started hysterically crying in the middle of the road because I was a child. Who thought it was a good idea to let children be around like dead, incinerated bodies, at your own will by choice at 16 years old? It's insane. So, I mean, 18 isn't too much better, but I mean, I give them props for starting early. I think that gives them a lot of room to grow and a lot of time to learn things, but there's a huge maturity aspect that goes along with it.
My first day on the ambulance, we'll scroll off one more second. I'll tell my first story. My first day on the ambulance, so I started as a volunteer, and the volunteer rescue squads, like if the ambulance needed a driver, they would call the rescue squad. So you'd go out and your POV, you would get in the front of the ambulance and you would drive code 3 licensed sirens, whichever hospital, and you were done. It's like, that was my job. I was like, cool, this is a fun gig. I should go to paramedic school. And so I get my EMT. First day on the job, we load the patient up and I just hop in the front seat and I sit there. And I'm like, hey, let me know when you're ready, paramedic. He's like, okay. So we sit on scene for 20 minutes. And I'm sitting in the front seat, just sitting there twiddling my thumbs. And next call comes out. It was a chest pain. I remember it. Like, load his chest pain up in the back of the truck. I go to hop up front. And the paramedic's like, hey, if you got back here and helped me, we could get things done a lot faster. I was like, oh, you want me to back? Oh, okay. Like, oh my gosh, I was so dumb. I was like, yeah, I'm an EMT now. I can help you. Let me get in the back. I'm like, oh my gosh. So yeah, I was really dumb.
We all were. So.
Oh my gosh.
Can't attest to that.
All right. The final thing, and again, this also I think applies to all calls, but we'll apply it to overdoses, is that dogs, children, and patients all have something in common, and that is that they can sense your energy and they mimic it, right? And I believe this wholeheartedly. Like, anxious people have anxious dogs. When parents are upset and angry, kids get irritable, right? They feed off of that, and patients do the exact same thing. And so, of course, this isn't going to work 100% of the time. Sometimes there's factors outside of our control, but generally, if we give off a calm and confident demeanor around our patients, then that's something that they're going to mimic and give back to us. So if we show respect, we show that we're calm, we are not being egotistical, we're not on edge, that is often what keeps those patients calm as well. And I know that's kind of, for me personally, the first step in my de-escalation technique with any patient is to check my own self and to think, okay, am I calm? Am I taking a step back? Am I relaxed? And more often than not, if I am relaxed and calm, the patient will be too.
Always pet the dog.
Always pet the dog.
Always pet the dog. That's the first rule of EMT 101. Dog comes up to you, you pet the dog. Always pet the dog.
It's the DABCs. Pet the dog, then worry about airway, breathing, and circulation.
Perfect. Yes.
Yeah.
Totally supported.
Well, and de-escalating your partner, not just the patient, de-escalate everybody around. You don't move any faster by screaming and pulling the first out bag apart on
Yep.
scene. You don't move any faster doing that than just calmly talking and going through everything. And I think we've all probably know, and work with people that freak out, even at the flight level, of that you have people that are just amped people.
Yep.
And in this situation, yeah, that makes a lot of sense to have people emulate your energy. I wish I could get that to work on my child right now, though. It's not working with my child right now.
So
I
if
try to give
you
off a calm energy, and he's just not calm sometimes.
so if you meditate, your baby doesn't also meditate in the
He
corner.
doesn't, the asshole.
Ah, damn it.
Just give him some bourbon. He'll be fine. Just put some bourbon on his gums. He'll be good.
Oh yeah. I'll
Oh,
do
great
it.
idea. I haven't done that already or anything.
Yeah.
That'll help him gain weight too. He'll be fine.
Oh, God.
So the last thing, I think it's the last thing, is this is something that definitely causes some controversial. Like if you want to get a fight going with EMS, is after I give a patient Narcan, can they sign a refusal? Do they have the mental capacity to sign a waiver? Who's liable? What happens if the drug they took has a longer half-life than Narcan and they go back into respiratory arrest and they go back unconscious? Who's liable? So I hear a lot of providers say, you know what, I'll give them just a little bit of Narcan and then we'll slam it right before we get to the ER. So that way we're already in the truck and we know we're going into the ER. So when they do start puking or they get combative, they're already going into the ER. But this is a pretty good discussion about you have a patient who had a little too much fun, took too much heroin, quit breathing, went unconscious. We've given them Narcan. They wake up. We did all of Lindsey's tactics. So they're cool, super cool, chill. They're fine. They're awake. They're A&O, alert and oriented, but they won't go to the hospital. How much danger am I going to get sued, or what problems am I going to run into if they sign that waiver?
Yeah, this is tricky, but at the end of the day, it's just not that big of a deal. And a patient who wakes up stable and without other obvious complications, right? So, we've all had the patient that had a complicated ingestion history, tox history. Maybe they vomited, maybe they aspirated, they took a ton of Narcan. Their SATs never came up to something ideal. Okay, right. Those patients are your guaranteed transports. We're going to do everything we can to get them to the hospital. But if you go to Google right now and you type in refusal after Narcan, there is actually quite a bit of literature on how okay this actually is in your uncomplicated patients. Yes, if someone used maybe a longer acting narcotic, maybe they overdosed on like methadone or kind of something off the wall like that, we might need to be a little bit more careful. But for your more typical narcotic overdoses, if they wake up, their SATs return to normal, they're alert and oriented, there's no other obvious complications with the overdose, there's really nothing that tells us that this is an issue. And these studies that looked at this monitored these patients for like 24 to 48, and in some cases up to 4 days after refusal to see if they arrested from something. And it just was not happening. It's like what I write down, 0 to 0.48% here is what I found patients that had complications after refusing, which is just so minuscule. And we kind of talked about this before the show, but now in COVID times, I mean, ERs and hospitals are so overwhelmed that is it worth it for us to transport these patients and talk them into it against their will when there's really no reason to? So statistically, from a medical complication standpoint, there appears to be really no good reason to do that. People will argue there's more resources for them at the hospital. I don't think we can really get into that here because we don't know what every hospital and facility has available, but there are tons of pre-hospital agencies that are getting more and more resources for these patients on their unit. So they have the Narcan they can leave behind. They have the contact information for rehab facilities. They have the addiction services resources that they can leave with the patient. So why are we taking up a very necessary hospital bed for someone that doesn't want to be there and doesn't need to be there? It doesn't make sense to me.
Yeah. And ERs, I mean, like we can make a generalization, I think, here in that ERs, especially a stress ER, is not where a chronic addict gets help.
Right.
Like sometimes, yeah, you might get a flyer, you might get a visit from a social worker, but I think it's safe to say in general in the United States, you will not get the help you need from that ER, right? That maybe you get a push over the edge, maybe it helps somewhere, maybe somebody's super spectacular ER has somebody that can handle it, but in general, nowhere I've ever worked is that the appropriate place for an addict.
Yeah, I agree.
Awesome. Well, I think that was some good conversation. I'm excited about it. Like I think it's something that gets talked about a lot. Like I know Sam has done videos on it. You've done Instagram posts, and there's always questions, even from like the civilian side, about should I carry Narcan? Do I really need Narcan? And there's a lot of questions. So I think we took care of a lot of those questions.
Yeah. Do you want to, before we wrap it up, just reiterate the low risk of law enforcement overdose from contact? I think we should talk about it.
I think Sam is itching to talk about this.
I want to talk about this so bad because I get so angry at these law enforcement social media posts, and this is nothing against the individual officers. I get it. It's a nocebo effect. It's hypochondriacs to the extreme. It's seeing media over and over again. But you cannot overdose on fentanyl by touching it or breathing in a little bit of dust in a well-ventilated area.
And
for
Sam,
those who are listening on the podcast, like Sam just slid up to the mic, like he's been chilled the whole time.
That was direct eye contact.
Right
he was
here.
Like he's staring at the camera. If you guys are on the podcast, you're totally missing this, but Sam was fired up for that part.
And so, Sam, when these law enforcement officers are feeling they can't breathe and their heart is beating fast, what is happening then if it's not an overdose?
Well, Lindsey, increased respiratory rate and a rapid heartbeat are the exact opposite of the signs of an opiate overdose. And if I had to guess, I would say that is a panic reaction induced by us scaring the living shit out of every law enforcement officer to go through an academy where they say a microscopic amount of this could kill this entire room. It's carfentanil. It's the most dangerous thing in the world. And I'm decently sure if fentanyl was as dangerous as Orange County Sheriff's Office is making it sound, I'm pretty sure we'd have some bioterrorism issues in the United States. Not an expert, but I'm pretty sure somebody would be using it to kill a whole lot of people.
We just lost a ton of subscribers right there. They're gone.
No, the DEA says it's real, okay? They have no reason to lie to me about it, all right? They say it's a huge problem.
But
I feel like you could do a whole podcast on this. Like I feel like we could do that one next. We'll do that one next. That'll just seal the fate. We'll be done as the podcasters.
I do feel like we need to point out though that the doggies are at risk, and the doggies from snorting powder, if they get their nose into it, may actually need the Narcan.
And that's the thing. A lot of people, like on the videos I've done on fentanyl, have like come back. They're like, well, people snort fentanyl and overdose, and that's true. But like, we know it as medical providers, but it doesn't seem quite as obvious. Is that snorting a line of fentanyl or coke that has fentanyl in it is a different route of absorption than inhaling particles. It's two very separate things. So a dog that snorts fentanyl or a human that snorts fentanyl can overdose from said fentanyl. And if you took like fentanyl powder and you put it in a bathtub and you bathed in it, you'll probably overdose on fentanyl. So it's not to say that dermal absorption is not possible whatsoever, but in these incidental exposures where a speck of dust lands on an officer's shirt, that's not an overdose.
And there's literally no documented cases of this, by the way.
Not a single one.
Confirmed overdoses of law enforcement officers by coming into topical contact with it.
No, they've never found positive levels in a law enforcement officer's blood. And I think there was one, and then they came to find out that he was diverting meds. So
that'll do it.
You know, that'll do it. So yeah, this can be a whole nother podcast. We'll do that next. We'll lose all the followers, and we can just retire.
Lindsey, if you want to come back and defend cops on this one, you're welcome to come back on the next episode and defend cops.
I don't think I have much of a defense on this one. I just feel bad that they've been scared to death and have been given literal anxiety disorders over this.
It's an educational thing. It really is. Like it is an educational problem that they have. And
But it's not just them, because that Orange County post where they posted about everybody dying of the fentanyl overdose, what did you see? You saw the fire department, like you said, suiting up in level A suits and doing a decon station and hosing people down and scrubbing them and wearing SCBAs. Like those are trained medical responders that are feeding into this. And granted, there's a time and a place for education, and that's probably not like in the moment. But like you should still be doing what's right, which probably isn't launching your hazmat team to go deal with this and spending taxpayer dollars treating a anxiety reaction with a hazmat team. That's probably not right.
Man, Sam is fired up.
And there's so many comments on my things. Oh man. All right. I'm gonna stop.
Whole episode. Next episode, we'll talk about it. It'll be fun.
All right. Well, we'll call it there, but I figured we should at least, give that a little bit of.
He was itching, like he was leaned forward, like he was ready to go for that one. So he kept.
Yeah.
Cool. Well, thank you so much for coming on, Lindsey. Can you just tell people where they can find you if they want to look up some of your other stuff?
Yep. So I'm on Instagram pretty much every day. The handle is the .prehospitalist. Again, I have a YouTube. It's not good. Don't subscribe.
Go subscribe.
Don't subscribe, but there's 4 videos. It's not good. But anyway, yep, you can find me on Instagram. I'm there most days and having discussions and posting things and answering DMs and such. So, yeah.
What's the magic number we have to get you to on subscribers to get you to start posting videos?
No, it just won't happen. I'm so not technologically savvy at all. Like
Can we get you to 100 subscribers or 1,000? Like
she's at like 650.
Oh wow!
I don't even know how many I have.
Yeah, you're at like 600. I just looked because I recommend your page on my page.
I would recommend my page.
You're at 676 subscribers.
Like I have this cool microphone here, right? It's not even working because I don't know how to get it to work. I plugged it in and it beeps, but it's not working. So
we could get you to 1,000. Get you to 1,000, and it's downhill from there.
I don't want to be at 1,000.
The first 1,000 is the hardest to get.
Send them to Instagram because I can crank out a written post in like 15 minutes. That's my sweet spot that I can handle.
All right. Go subscribe to our YouTube channel just to be funny. Before we go, I do want to, I promised my EMT class I would talk about them. So I had a group of EMT students that I helped teach. They're high school students. They took their practical exam today where they do 4 stations. And they all passed. We had 100% pass rate. So there was one like throwing up before, and I was like, "Stop it! Stop throwing up! You're gonna make me throw up." But they all passed. So they listened to the podcast. So I just wanted to tell them I'm proud of them. So
congrats
class.
Bless their hearts. They had the worst instructors, so they end up passing. So good job.
Come to Colorado. Come work for our service.
Nope, I'm already hiring them. Like, come work for us. Let's do it. So it's a great academy program. But yeah, I appreciate it, Lindsey. Thank you for coming on. So
yeah, thanks for having me.
Putting up with our shenanigans. Anything else, Prep Medic? Sam, you good?
That's all I got. Have a good night.
Awesome.
Bye, guys.